Hello, Dr. Vissing. Really nice to be with you. I just want to say welcome. This is a really important topic at a really important time. We have a massive challenge in both the rate of birth trauma and the rate of mortality for children and women during birth. And it is not a shock to me that those two things would overlap. But very rarely do you have somebody who's thought both so deeply clinically and had such a depth of clinical capacity in the somatic realm to create a protocol that supports the healing and wholeness for both infant and maternal health. I want to just start us off for just a moment. Uh, uh, um, my name is Dr. Chingaris. I'm a health psychologist, and I am one of the board members for Northern California Somatic Experiencing Professional Association. And I'd like to ask if Gwen would be willing to say hi and introduce herself.
Hi, everyone. Thank you for coming. Thank you, Dr. Vissing, for your presentation. Yeah, I'm a board member for NorCal SEPA, and I'm not sure where you are all located geographically, but we're having a potluck at my house in Concord on May 19th. It's a Sunday from 11 to 3. So you are all welcome to attend, and I can actually put the RSVP link in the chat. So hope to see you there. It's our first in-person event in many years.
And I would love to invite you all to join NorCal SEPA and help us grow the SE presence within the Bay Area. We need leaders, we need people with heart, we need people willing to grow community. And one of the things we know from SE is that if you get people together and you connect, good things happen. So we're trying to create a place where people can come together and connect. So welcome to the Northern California Somatic Experiencing Professional Association Mark Schuler Speaker Series. Mark Schuler was a beloved body worker and somatic experiencing practitioner in the Bay Area and bequeathed some significant funding for this particular training series and a few other topics. And so we're in deep gratitude for him and his wisdom, which will continue to grow and spread. I'd like to let everybody know that we have another event coming on May 26th at noon to 1:30. And this is with Denise Jurado, I believe Springer, who has pioneered somatic integration and archetypal paradox. Please join us for that. We'd love people who would consider serving on our board or our committees to help us lead the way in Northern California. This is our 6th speaker event, and we're grateful to have such a talented and impactful leader with us today. We're grateful for Dr. Helena Vissing to help us embody SE and support our practices in our communities. She brings a depth and skill. Gwen, do you want to read the land acknowledgement, or should I do that one?
I'm sorry, I don't have it handy, so you go ahead.
No worries. So Northern California Somatic Experiencing Professional Association encompasses the 48 northern counties of California. We acknowledge what we call Northern California as an occupied territory of over 100 tribes and has been stewarded by indigenous people for millennia. Those of us in the Bay Area, for instance, are living on unceded Ohlone territory. Nevertheless, the first peoples of California are still present, and their connections to the land and water endure. We recognize that tribal communities and preservation of traditional ways of life depend on secure and permanent territories and the right of self-determination. We further acknowledge that modern-day somatic approaches and trainings, including somatic experiencing, owe a debt of gratitude to traditional indigenous healers worldwide, whose practices have been studied, absorbed, and monetized, often without recognition or any payment. Our objective in Northern California Somatic Experiencing Professional Association is to sustain all members of the Northern California region so that we may in turn support the community at large. We will continue to be very much in need of trauma healing work due to the ongoing exposure to racial violence, oppression, and natural disasters amplified by climate change. We want Northern California SEP to contribute to dismantling the systems and structures that perpetuate white supremacy and be a force of liberation. We need your help and participation to accomplish this. All right. So I'd like to welcome Dr. Helena Vissing. She's a dear friend who I've worked with on a number of research projects, somebody who I admire deeply and appreciate her capacity and leadership. She is going to be presenting a workshop on somatic maternal trauma healing in the perinatal period. Dr. Vissing is a distinguished psychologist and certified in perinatal mental health, brings a wealth of knowledge and experience into this session. Her practice encompasses psychodynamic and trauma-informed somatic psychotherapy and specializing in the integration of somatic approaches to pre and perinatal mental health. She has been a professor at multiple prestigious universities, including Antioch and the Chicago School of Professional Psychology. She is an excellent teacher with tremendous depth of wisdom and heart. And I'm glad that she is here to share her time, talent, and skill with us today. Thank you so much, Dr. Vissing. And without any further ado, I'm going to pass over to you. And I'm sorry for everybody. I'm having allergies for the first time in years, so I'm not used to talking with them. So I'm a little sputtery today, but thank you for your presence and your kindness. Thank you, Dr. Vissing.
Thank you so much. Thank you. I very much appreciate it. I'm very happy to be here, to get to be here with you all, that I get to come here and present and also connect with you all. Yeah, I also wanted to add here, I'm speaking here from Auburn, right outside Sacramento in North California. I just want to mention in continuing related to the land acknowledgement that just if anyone would want to consider the California Heritage Indigenous Research Project, nisinan.org, they have a big project going on with restoring land that they're in the process of buying. So if anyone would be interested, you can read about that on nisinan.org and donate to that really important project. And that's that Nisinan, it's that tribe where I am here locally in the Auburn area. I just wanted to start by just inviting everyone to take a moment, because it is, we are a somatic organization, and I just want everyone to take a moment to notice your transition into this. We're coming together here, connecting through technology. So even though we are physically separated, we are connecting too, and just take a moment to feel that connection. It's not abstract, it is very real. We can hear each other's voices, we can see each other, we are holding each other in each other's minds about this topic that we come together with a shared passion for. So just wanted to invite you to really feel that, the experiential realness of that, just to take that in, how we are here coming together, connecting. And in continuation of that, with the connection, we are going to talk about something that it has many sides to it. We are talking about trauma, mental health issues, struggling emotional issues, systemic issues related to this, vulnerabilities, and that's heavy and can be activating. And we all carry that vulnerability in ourselves from our own stories and vicariously the people we work with. And at the same time, when we are talking about trauma here, we are talking about healing. We're never just talking about trauma and pain and suffering. We're talking about it in the context of healing and hope. So I always find that very helpful, because when we talk about somatic experiencing, the training that I'm assuming many of you here know about. It can be it can be very heavy. It's hard training because it's very intense work, and certainly this area of perinatal, when we talk about perinatal trauma, can be heavy. So yeah, so I'm just wanted to bring that reminder in before I pull up my slides here, which I will do now. Let's see. Okay. Pulling up my slides. Share screen. Here we go. Here are my slides here. Okay. So I am used to presenting from this slide while also keeping an eye on the chat. So I welcome if you need to make any comments, questions, anything you want to get clarified, I welcome you to do that in a chat. I'm fine with that. And if there's something more, I might invite you to just unmute. And then I also will make sure to have time by the end for more in-depth Q&A and discussion. We do have until 1:30, so that's nice. So it's not just 1 hour, gets a little crammed. I mean, I want to say I'm going to give an introduction, but I did write a book about this. This is the book. It's based on somatic maternal healing, so I won't be able to cover everything, obviously. There will be a bunch of things that I won't be able to get to. So just wanted to be mindful of that. But hopefully this is the start. And if you have more interest, right, we will be able to continue the conversation on this. So when we talk about perinatal mental health, maybe some of you have heard this term PMATS. It stands for perinatal mood and anxiety disorders. As we know, these diagnostic terms, they are diagnostic terms, right? They are part of these categories, these systems. They are the reality of our world in the fields of mental health and the helping professions. We need to reckon with them. We also know that they are very limiting and they're not neutral. They carry all kinds of connotations. So what's important is to always see, they are just at the top of the iceberg. They are just the surface, right? They are that, like, the way it presents, the way it's talked about, and for example, the research, a lot of the people we serve, that's also the what they know, what they're presented with. And it's really important that we know, like, that's kind of the top of the iceberg. And then our work is really when we go below. I love a good iceberg metaphor for that we are always going below to get a full sense of what is really going on. So what is going on here? There's a lot going on. This is not an exhaustive list at all, but these are just some of the things. When we kind of go under the surface, we can see what's going on. We know, of course, stressors, also toxic stress, grief and losses, very big factors. Inflammation, there's a lot of amazing research coming out looking at from the biomedical world, looking at inflammation as a big factor. We also know that there are a lot of systemic dynamics, systemic discrimination, othering dynamics, patriarchal motherhood. Maybe some of you have heard of that term. There's also intensive mothering ideology, things like that on a cultural, psychosocial level. Oh, we also know we have big issues related to inadequate care, the iatrogenic effects of the perinatal care system, and how all of this impacts the perinatal embodiment, which I will talk more about that, how it impacts the body and causes perinatal bodilessness, which is basically a disconnect from the body in relation to the perinatal. So this is just, I mean, there are many more. I'm sure you could come up, and feel free to add in the chat if something comes to mind. There are many more things, right? It's not exhaustive. And all of this, of course, also relates to trauma. Trauma is a big piece of that. As you can see, these terms here, they kind of address trauma from different paradigms, from different perspectives. So as we know from a somatic perspective, when we talk about trauma, we have to talk about the body, right? There's no way of getting around that. So I put here the body as a question mark because the way I see it in the field of maternal mental health and perinatal mental health is that there's such a neglect of the body. There's only now, this is only now fully coming in. I've been specializing in this field for more than 10 years. And when I started, there was just in the mainstream kind of perinatal specialization, when you look at the literature talking about PMATs, right? There is just there was no focus on the body, let alone somatic. It was very hard. So now I see myself as being part of this shift. I want to be part of this conversation that is really working to integrate and to bring the body into this work. So trauma is a difficult term. And we could spend a whole day talking about the different forms of definitions of trauma. Of course, there are different ways of seeing it. As we know in the somatic world, somatic experiencing, the way we understand trauma is the holistic psychobiological responses to overwhelm. So it's the way, of course, on the bodily level, how all the systems on a bodily level are impacted by trauma, but also from Peter Levine's understanding, the systems that are impacted by trauma are the same systems that are also, or the same dynamics that are related to our vitality systems and our aliveness, right? So we see that connected there from Levine's model. So when we talk about perinatal trauma, what's important for me here is to look at the unique ways that trauma can happen in the perinatal period. And that's really important because trauma is a lot of different things and affects different people in different ways, different groups, different peoples, right? And depending on what they're dealing with and the unique vulnerabilities. And there's a really unique vulnerability to trauma in the perinatal period. So I see, when we talk about perinatal trauma, I see it as the trauma reactions in response to the stressors of the perinatal transition. And then when that is interacting with the individual parent's history, the physiological adaptations of reproduction, the medical interventions, iatrogenic effects, the subjective experience, becoming a parent, and the systemic cultural context of oppression that the parent is embedded in. So these are interacting factors. Sometimes one of them is like a main side of trauma, but they exacerbate each other. This is what we see most often, is that all of this will exacerbate each other in that way. The historical context, I didn't mention it here, but all of this is also seen in the historical context, obviously, of the historical context of perinatal care, for example, at this moment in history. Excuse me. So I wanted to develop an integrative biopsychosocial model. I was inspired by feminist relational psychoanalysis because I have a big passion for that. I was very interested in psychoanalysis. I wrote my dissertation on psychoanalytic exploration of motherhood and the psychology of motherhood. Excuse me. And I found that although there are some amazing developments in feminist relational psychoanalysis, it was not enough, because that paradigm and perspective didn't fully take into account the developments going on in the biomedical field. And we know there's been some very important developments there. Fields like psychoneuroimmunology, there's a very important research related to postpartum depression. and maternal neuroscience, looking at how pregnancy and postpartum impacts the brain, which is a field in its infancy. We're going to see some amazing research coming out. Of course, the whole field of somatic psychology that we know, often also called interpersonal neurobiology, where we know there's a whole field of literature there. There's so much going on there we need to look at for understanding perinatal mental health. And you would think then, oh, then that's really solid, right? Like psychoanalytic feminist theories then and all the biomedical to understand the body. But that's still not enough, right? We need the psychosocial perspective. We need social analysis. We need to look at that level of analysis to understand these social, cultural, historical, systemic dynamics. And that's where I found that matricentric feminism, which is a branch of feminism that looks specifically at mothering and parenting and how that is the political salience also of mothering and caregiving, comes in with a really important analysis and critique of some of these other things and really brings in that societal level, societal perspective. And I found that incredibly important to bring that perspective in too. I see it in this way as a biopsychosocial model that will center trauma because of when you look at this research from the different areas, you see how trauma comes up again and again along with the body, right? Because trauma and the body cannot be separated. So I know that the biopsychosocial model is not like perfect in that way, and there's been critiques of it, of course. I don't see it as a static model. It's not a protocol. My approach here is not protocol based at all. I see it as a dynamic model, and what I mean by that is that whenever we're engaging with one of these three bubbles, we need to look at how one area is informing the other areas, as well as how the other areas is challenging that area, right? How, for example, how is matricentric feminism challenging the blind spots of psychoanalysis or challenging the blind spots of biomedical research, right? So it's a way that they are informing each other and challenging each other's blind spots. So it's always like a dynamic model in that way that should, every time we're studying something in one area, that should bring up more questions, more things to reflect on for the other areas too. So this integrative model, the way I see like the main things I wanted to integrate here is that from a somatic level, we need to look at nervous system regulation. I mean, this is a technical term. This is like for a clinical perspective here, right? An integrative model for clinical work. Nervous system regulation, I mean, it sounds limiting, right? Because nervous system regulation is so much, right? We're also talking about co-regulation, of course, and relationships there. But that's one of the main things, is to look at what's going on a nervous system level, on a bodily level. And from that feminist psychoanalytic perspective, or what we bring in there, is that maternal subjectivity is a very, very important thing. What does it mean to mother? And by extension, we can also talk about what does it mean to be a caregiver, all for all parents. My main focus is maternal mental health. I will talk a bit about how, like, the perinatal mental health is of course wider, and then there is maternal mental health. But somatic maternal healing, this model is not isolated to that, right? This is the start, and for future projects, I mean, in the future, I'm imagining really expanding this, and I invite anyone with an interest to join me in expanding this, as we talk about, the healing for perinatal in the broad sense. But my focus has been maternal subjectivity, to understand subjectivity for mothers, but that's a big philosophical question. Hopefully I'll have time to go into that, but like there's a whole chapter on that in my book. There's a lot to that of maternal subjectivity is a big philosophical question that really challenges the very idea of what is subjectivity in the current sense here in like the Western culture sphere that I'm situated in. What is our understanding of what does it mean to be an individual, to be a subject? Maternal subjectivity is a big philosophical question that opens that up. And also how that links to somatic psychology is that to talk about countertransference, in the classic psychodynamic sense that, countertransference dynamics happen. We understand that clinically. That really has a somatic component that are very specific to the perinatal field, meaning the somatic aspects of transference, clinical transference, are going to be specific to working with clients who are dealing with fertility, conception, pregnancy, postpartum, and caregiving. And that's a really important thing. The people we work with, all kinds of groups, right, have different experiences with embodiment, and that brings up different things, right? So this idea that we could kind of have a general approach to transferential work is problematic because because bodies are different and people are different. And then here, there are some very specific things going on the bodily somatic level, obviously, when we talk about maternal mental health. And then matricentric feminism is this branch of feminism that really insists on the political layers and cultural political layers of the maternal transition, and how the idea of mothering is something that there are very problematic oppressive dynamics related to what maybe you've heard the term institutionalized motherhood or patriarchal motherhood. This is the famous distinction from Adrienne Rich, who talks about the difference between the institution of motherhood versus a person's personal potential for mothering. And it is in that distinction that we can start to understand mothering as something that can be empowering. That can be a way of asserting oneself. It can even be related to free speech and asserting oneself in that way. And empowered feminist mothering is like an activism branch of that. There's a whole body of literature on that, of understanding mothering as politically powerful, that I also wanted to bring in that way. So these are like the clinical, practical things that I wanted to draw from. So we have time, full hour. Okay, so I want to just to maybe go in depth a bit more about these areas. I want to be mindful not to spend too much time on these because of course, if you want to really dig into it, you can go read it, because I want to make sure we also have time to then talk about, okay, what are the clinical implications? But just some highlights here. And in my book, I have like a chapter for each of these. But to give some highlights, we now know that there are really specific neurological inflammatory things going on. One of the lead researchers on this in health psychology, Kathleen Kendall Tackett, who's specialized in this for many, many years, she says that inflammation is not a etiological factor, it is the etiological factor. It is crucial to understand, which is because there are a part of that whole pregnancy and postpartum transition, there are inflammatory responses in the body that is necessary. It's necessary to go through that, especially in the first trimester, so the fetus is not expelled from the body. And then again in the third trimester, when the body is preparing for delivery, the cervix will be open for some weeks after delivery. The body has to protect itself from infection. These are some really powerful biological dynamics. That has a very unique, a very delicate system in the body on that neuroimmunological level. And now it's relatively recent that we're starting to research this and look at how this is posing some vulnerabilities, right? So also the way that the neurological plasticity of the brain, it makes a lot of sense, right? We are preparing for caregiving. The brain actually undergoes enormous pruning and changes, and we have to look at that in the sense of a vulnerability. But at the same time, it's important that we don't only look at it as like a vulnerability factor, because it's also a really unique opportunity for healing. We also have to consider how this is a growth, an expansion, a specialization of the skills from a somatic level. We become so specialized. We're able to transition to prepare for this really unique job of caregiving. And all of this is experience dependent, right? Like this is based on the experiential factors, right? So we are born with these like innate mechanisms on a bodily level, and all of those mechanisms they really depend on being kind of practiced in the experiential through experiences. So I want you to consider, when we talk about trauma, the vulnerability piece here, I want you to consider that most people know you don't necessarily have to be have a special knowledge about pregnancy, but most people we know, right? Like pregnancy impacts the body in so many ways, like all of the systems. These are just some of them, right? Gastrointestinal, all of this, right? A lot of things is going on, and the research is there's still so much we don't know about the physiological changes. It's really massive, these changes. And then consider also what we know about the physical impact of trauma. And I think these two here, the physical impact of pregnancy and then the physical impact of trauma, I think a lot of people, I mean, certainly people in our field are much more aware of the connections here. And those of you who have an interest in this, I think still both researchers and also a lot of lay people, we have a lot of more understanding of the physical impact of trauma. There's much more talk about that in public discourse. There's also kind of a general knowledge, like most people, more and more people have general knowledge about like these medical aspects, but then putting them together, right? That's what I see. My experience is that this is what's really missing, is to look at this together, to look at how, consider, I put PTSD here because of the specific, the research literature that is very PTSD focused, which is can be problematic because PTSD is this very specific presentation of trauma, and it's not all trauma. And the trauma research literature has been dominated by PTSD, which is specifically problematic when we talk about perinatal trauma. But all of this research here, we have lovely research, right? The ACEs study, which is becoming more and more known in the whole field of mental health and just the medical field as a whole. But the way that basically all of these very delicate systems that we know are impacted with trauma are also acutely involved in the whole transformation of pregnancy and postpartum. So this is this perfect storm when you talk about the vulnerabilities of the maternal transition and then talk about trauma. No, this is a very confusing and overwhelming model here. I don't expect it to like make a ton of sense, but every single line here represents a significant body of literature indicating a relationship. And with the red lines indicating very, very strong associations where more and more research, and this is like I spent a couple of years combing through the research literature, and this is just the magnitude of how complex it is. I know it's not very like simplified, but this is the magnitude of how complex, how many systems are at play here. And every single one of them, you could go into all the research and knowledge we have about that and see that all of this connects to when we talk about PMATs. So I just want to shift now to talk a bit about the psychological. So we see obviously really more and more knowledge about the vulnerabilities from a biomedical level of analysis. And then if you can kind of switch gears, now we're jumping into a different paradigm, different way of thinking. I know sometimes it can be a bit like, it can be a lot, but I found that I like that for some reason. I really enjoy this thing of like jumping from paradigms to paradigms, different ways of thinking. I find it very energizing in some way. I understand if other people like that's not necessarily for everyone. That's how I work. So when we talk about feminist psychoanalysis and the question of this, then we have to really think, I mean, you could say not just feminist, also philosophical psychoanalysis here. It's a philosophical existential question too, because this is an epistemological question. What is maternal subjectivity? What is subjectivity? What is our notion of selfhood in Western culture? I draw here on some amazing scholars, for example, Alison Stone, Lisa Baratzer, and others who talk about how the way we have developed this understanding of selfhood in Western culture is really based on separating from the maternal body, separating from the maternal, that to be a self means to separate. And it's not just separating from the mother as a person, it's specifically separating from that co-regulatory realm, excuse me, that we know is the foundation of being a human. This is how it starts. We start in co-regulation, that nonverbal, acutely affective, highly sensitive co-regulatory realm that we now have an enormous amount of research showing. I'm thinking here of the whole mother-infant or caregiver-infant research literature, not just the theoretical research, but this is backed up, integrated from all the developmental research, Beatrice Beebe and others, right? So Benjamin here, as you see, I refer to Jessica Benjamin, who is, I think, one of the most amazing thinkers of our time, and also an amazing person. I've got to meet with her. She did some very important work back already in the 80s, where she wanted to connect the way that psychoanalysis was developing to a more relational way of thinking, and then bringing in the new data from developmental psychology and mother-infant research. She said, we need to integrate this. So I'm of course very inspired by her also being this integrationist. And she for her, in her work, when she was doing this work, she actually volunteered with or worked with Beatrice Beebe. And then she was inspired by psychoanalysis and Hegelian dialectics. And she said, well, the missing piece here is the mother as a subject, right? And there's something about this that's really impossible. She talks about this tension between our mother is like our prototypical other, but how do we come to see, and mother here is also understood very broadly as primary caregiver. And Benjamin's model is she talks a lot about the flexibility and fluidity around gender, and her model, her philosophy is actually very flexible around that. She talks about the relational third, which is very flexible in terms of gender. I won't have time to go into all of that, but I would encourage you to go into that if you're interested. But so when I say the mother here and the maternal, that's not always literal. It's also understood very broadly. Excuse me. But the maternal there is we know it's also gendered in cultural ways, where it is that other, our first other who is a subject, but also an object to our needs, right? We have this inner world where our first, other, the mother is like seen as like the caregiver for our needs, but it's also a person in their own right. And that is a tension in itself. But Jessica Benjamin says, well, it is namely in this tension that we come to also become subjects ourselves. So it is this tension where I need my mother to be a person in her own right, because I need her to be that so that she can reflect back to me my subjectivity, so we are both subjects recognizing each other. But that's also the problem, that she has a mind of her own and we can disagree. It's like the sting of otherness, and that we struggle with. And Benjamin connects this with, on that early mother-child level, all the way to like political science, and talk about politics in a psychoanalytic sense in that way. So what's really problematic here is that we have a lot of amazing philosophy about this, about maternal subjectivity and embodiment, and how it starts from that embodied co-regulatory realm that we then in this cultural context have to separate from. And the maternal is still very paradoxical in modern society, also because we have this on that psychosocial level, we have this public-private split where the maternal body is like the maternal, also the feminine, women are often associated with the private realm versus the public. And even if you can say concretely, women can go out and work and obviously are in the public sphere, these dynamics of the public-private are really intense and are characterized by how caregiving in the private sphere is not paid, right? Whereas the public sphere is characterized by paid work. You also see how caregiving work is generally paid less. So the gendered fields of work are often paid less, very generalized, roughly said here. And it is this like tension here going on. What the body, what's really important to see here is that that whole realm of being a mother and the bodily realm of that we work with in our work, with people coming to us, is so marked by this public-private split, and this, that it's hard for us, sometimes our language doesn't really capture it. So there's some problems, right? It's philosophical problems. So consider then these problems also in relation to trauma again, right? So we know that the fluidity of body boundaries are necessary for caregiving of a baby. You undergo a whole shift in your sense of self and body boundaries if you go through pregnancy and birth. So there's this whole shift in that, where there's this investment in your child, right? It's almost like the child is a bodily part of yourself. Your nervous system is like extended in that way. Excuse me. If anyone of you work with new moms, like a classic example is that a new mom is like if she just had a baby, I mean, not especially the early postpartum, but even the first year, I would say, if you observe a new mom, you'll see how she will respond in her body directly the way that what's going on with the baby. Like, say her baby's sleeping there. Say you come into the room and the baby's in a cot and she's there, and you do something to the baby. Like, say you say boo to the baby, right? Like, you'll see that she will respond in her body as if you did it to her body, because she is so acutely attuned. So almost like she experiences the baby as an extension of herself, right? I mean, this is like very generalized, all things considered, regardless of if there could be other things going on. But we see this general, like, an intense attunement, which makes a lot of sense. So let's consider this also in light of trauma, right? There's almost like a destabilization of the body self that needs to be there in order to do the kind of caregiving that humans need. And then consider how also what we know about trauma from a psychological perspective, that trauma, I mean, is a lot of different things, but at the core of it, trauma is about a destabilization of the body, of the self, of a sense of self. There are many different theories that have different language for this, about it's like there's an internal split, there's a sense of alienation from the world. People who are survivors of trauma will often talk about the sense of alienation, disconnect, enormous disconnect, internal split, things like that. So it's so connected here, the sense of self. So imagine then undergoing this challenge of restructuring your sense of self. It's really challenging for the new mother. You are embodying a new maternal self, and you're embodying this relational realm with the baby that is perceived as being the contrast to being a self. And then add on, if any amount of trauma in that. So it's like it's a perfect storm again, right? And this is what we see so much in the clinic, is that we see this clash of trauma, where the whatever trauma it is. And what I'm saying trauma here, I'm talking about all the forms of I mean, any form of trauma are can impact mothers, and there are certain forms that pose particular risk. For example, mothers who are survivors of sexual abuse, and also adverse childhood experiences, attachment trauma, experiencing trauma in relation to the maternal transition, difficulties conceiving, fertility treatment problems, miscarriages, pregnancy losses previously. Also, if there's a family history of that, so vicariously or relationally, intergenerationally. Having traumatic experience related to the birth, the delivery, having traumatic experiences related to the care, the prenatal care, the postpartum care, all of that. And we know also the systemic levels here there are some disparities that are incredibly concerning, where there are these I'm talking here what we know from the US. We have focused on this for a long time, but there are just really issues with disparities and very insidious dynamics of discrimination, where mothers with, for example, BIPOC background, or mothers from like a low income background, in that way we just see a disproportionate negative outcome, adverse birth outcomes, adding to this, right? So there's such a vulnerability, where and there's more and more knowledge of that, so I want us to then connect it to the more of this like psychosocial way of thinking. And I found a practitioner, or a writer, a theorist and writer and trainer, Christine Caldwell. I'm very inspired by her work, and I found her work very helpful. She does not focus so much on trauma. She talks about body fullness and bodilessness, which I found very helpful for understanding perinatal mental health and what's going on. She comes from a dance and movement background, and she writes a lot about how we can understand ourselves and our sense of selves and identity from that on a bodily level. And before she talks about her term body fullness, she's written a book titled Body Fullness. She talks about bodilessness. She talks about the issues we are dealing with in our time. What are the ways we are disconnecting from our body? What are we seeing? And we see ways the body is ignored, dismissed, and this is on individual as well as on systemic cultural levels. We see this tendency to turn the body into an object or a project. So even people who will say, oh, we're very into the body. Well, it's all body hacking, for example. It's all about, taming the body, making the body perfect in some sense. Well, she says that's actually part of bodilessness. That actually ends up becoming a disconnect from the body, because she's talking about the body, not as an idea, but the body as experiential reality. We certainly see a lot of hatred, negativity towards the body called somatophobia, which, of course, comes in also with other forms of discrimination. And then when we are making others' bodies, our own bodies, wrong, somaticism, the way that people are like discrimination is exercised to creating hierarchies of bodies. I mean, that could also be, for example, all of the different forms of oppression, like racism, ableism, sexism, for example, is all related to that people's worth are being tied into their body and the functionality of their body. And that is being used to kind of judge, right, and create a hierarchy of bodies. So I know many of you here having an interest in somatic, you're very familiar with this and all the many forms it manifests. So I found this really helpful to do an analysis of how we see this impact mothers, all caregivers, and certainly mothers. What I call perinatal or maternal bodilessness. I see that we have a lot of ignoring of the perinatal body, where, maternal perinatal sensations, we don't even have language for it. We have a big issue with lack of research, and there's, in the whole biomedical tradition, there's certainly some improvements happening in the biomedical field. I love to collaborate with the people in the field, of the obstetric fields, who are determined to improve that field. But traditionally, in the history of that, there's a long history of medicalizing the perinatal body. That if you really look at that broadly, there's a very awful racist history of exploiting and doing experimentations, and in this whole medicalization, the maternal subjectivity, like to be a mother as that's who you are, is completely split off from the maternal body. If you just listen to the language of obstetrics, the maternal body is defined by its functionality. There's a lot of also negativity, the shame around postpartum bodies, the way postpartum bodies are also the hierarchy, right? If the celebrity culture around bouncing back, right? So if you're untouched by the perinatal transition, that's better compared to if you have very visible signs, right? That's somaticism. And of course, the othering of non-normative perinatal bodies, right? If you are not thin enough or wide enough or straight enough, or the way you present, right? Anything where you're not fitting into these ideals. And these narratives of then like the failures, right? That it's much better if we can go through the maternal perinatal transition without being so impacted by it. So this is my experience in the field, specializing in the field clinically, also in the all the different forms of literature. Also, this is also when you look at all the non-professional literature, all the memoirs and fiction and novels and poetry and nonfiction, kind of for a general audience. There's a ton of literature that describes all of this. So matricentric feminism here is, as I mentioned, it is this branch of feminism that builds on Adrienne Rich's distinction between motherhood as a patriarchal institution and ideology, and then motherhood as an experience and practice. And I found that this is important when we talk about perinatal bodilessness, to really look at the way that mothers are oppressed in specific ways, and they deal with specific forms of specific issues. And Andrea O'Reilly is one of the big names in this branch of feminism. She talks about that there is a need for a distinctive feminism for and about mothers. And because mother and woman are obviously not synonymous, and we need to acknowledge the political dimensions. You'll see here Collins here, that is Patricia Hill Collins, who is a very important Black feminist. We cannot talk about matricentric feminism or maternal studies without acknowledging the influence of Black feminism that has been really crucial in kind of critiquing these like assumptions about motherhood and motherhood culture, because there's a strong tradition there of really challenging those notions. So also Andrea O'Reilly has also drawn a lot on that. So that's that political level too, where mothering is individual, but it's also happening in a communal context. And mothering is also understand broadly as mother work, where Patricia Hill Collins has done a lot of work here of reconceiving, having another understanding of it, challenging these lines between saying that mothering is something that is only what you do at home with your children, where she says, no, like all the work you do is about the, to ensure the survival of your child is part of mother work, obviously coming from her research, where she looked at how that was the reality for so many women who were not, for example, middle class, upper middle class, or white. So she's really questioning the universality and bringing in this element of empowerment. Also the term other mothering, maybe you've heard that. So that again also really expands this idea of mothering as like mothering is something that's happening in a relational context, in that family, in the community, in that community, in that collective context, which is also really important to challenge that idea of like the separated individual, right? So there's a lot of dictates going on. This is a long list, and I don't even think this is exhaustive, but a lot of these dictates that are working in really insidious ways. There's also, I don't have it in here, but with these dictates here, there's a lot of literature on something called intensive mothering, which is basically kind of the cultural tendencies and cultural dynamics where with which these dictates are kind of distributed. And there's a big body of literature going back to it goes way back, but Susan Hayes in the 90s did a lot of research on this, looking at how these ideas that to be a good mother, it means it has to be very intense, and a lot of also contradicting messages towards mothers, just like this undue pressure on what mothering is, and that you're supposed to live up to all these ideals, and the systemic structures are actually not in place, so you're kind of set up for failure. And Andrew O'Reilly says that, well, if you can't live up to this, or if you don't want to live up to it, right? The both. Sometimes it could also be you don't want to. Then there are these dynamics where that you are being positioned as a bad mother, right? So these dynamics are happening in very subtly insidious ways. And that's something we need to keep in mind also for when we talk about the bodilessness, the embodied somatic experience of mothering is completely tied into this, the different practices. And it also shows us how, in a certain time, for example, you have a child, like all the things you're exposed to from, like, say, the doctors, the medical systems, other like official sources telling you, or what people around you saying, this is what you should do or shouldn't do. That is so historically connected, right? It's really easy to go back through different history and see how people used to tell mothers to do something, and today we'll say, oh my God, that sounds crazy, right? And also when you consider different culture, right? There's not one right way of mothering, even though so often the official stance on mothering is that no, we know there is one right way of doing it. If you consider the research, this is what you're supposed to do, and that is the right way, the objectively right way. And we know that's not true. There are ways that are that make sense given whatever is accessible, but there's no such thing as a pure knowledge about mothering outside of all these cultural historical dynamics. And in matricentric feminism, there is this understanding that that so often, even when there's like good intentions, what happens is that these dictates end up being oppressive, because it's about making mothers kind of fit into a norm and live up to certain things where their agency is restricted. So in matricentric feminism, we talk about the 5 tenets of agency and autonomy, authenticity, authority, and advocacy or activism. And what I love about this is that agency is something we also know from trauma-informed work, from the principles of trauma-informed care. Agency, self-determination, autonomy for the people we work with, nothing about us without us, right? People need to be involved and engaged. They need to have their own voice in it. They need to find their own sense of authenticity. So what's so important here is that when we work with mothers, to never come at it with this idea of like that we're experts instructing mothers how to do. Not even with somatic techniques. What is crucial is to help people find their own sense of agency. We can offer what we know from for example, the whole amazing field of somatic psychology, all the techniques and exercises and things we know. But ultimately, it needs to be the mother herself who finds that, right? And I mention that because, for example, with all this new wave of somatic tools in kind of more of a general discourse for the general population, which is wonderful, you can, and I experience this sometimes. I have clients where they're dealing with postpartum depression, anxiety, and also they maybe have had trauma, that will be very into somatic techniques and self-regulation. But it's coming from this place of like, I need to make sure that I am regulated so I can be a perfect mother. And I should not be dysregulated. I need to regulate myself because otherwise I will harm and hurt my children. And then I'm a bad mother. And I need to just really be excellent at my somatic stuff. I need to do endless amounts of somatic exercises, right? Like you can hear, I'm exaggerating, of course, but you can hear like that's where it ends up being co-opted, where from a mattress-centric perspective, I would say, no, the point of using somatic, for example, somatic experiencing, is not so that we can make sure that you're a perfect mother for your children. It is for your sake. It is for your healing, and it's to empower and support your experience of finding your new sense of self as a mother in a very embodied way. That your transition is not just this abstract role transition of like, oh, my new identity as a mother. It's this abstract thing. No, it's a very real embodied transition. It starts from the body. It's this is my belief here, following Christine Caldwell, and what I also from my somatic training, is that our sense of self is something that builds from the body up. We can have more, the abstract concepts comes up of how we see ourselves and roles and archetypes and things, and how we move in the world. But like that builds, the building blocks of that is bodily experiences. And that's why I also see that in the clinical work. So these are all just a recap. This is what we need to kind of target. This is what we look at, right? This is what needs to be addressed, because this is where the tension is happening. So there's a lot of things to work on, obviously. So this is very overarching, but the way I see it is that there needs to be an overarching goal here where we come in as support, co-regulatory supported, because of course we work relationally, and co-regulatory, I feel like is a bit of a synonymous with relational, where we somatic work is always relational, and we are anchoring that reflective work. If you are, for example, doing talk therapy, we're anchoring that in that co-regulatory support, so that that's the support for the mother to mourn, because there's inherent losses of the transition, the play, to process, to release and heal trauma. And then when there is that container, we can move towards exploring, synthesizing, integrating this both verbal and nonverbal expression of being a maternal embodied subject, the maternal embodied relational subjectivity, to be a mother in an embodied ways, right? So we need to create that container to support that, which I call maternal bodyfulness. So there is, on the second point here, there is an inherent vulnerability in the maternal transition. We know that. We want to balance that with this potential for deeper healing on all the different levels, biopsychosocial levels. So we aim to support the mother in asserting her new subjectivity through maternal bodyfulness. So this is actually a repetition of that with the recap. So I'll talk more about maternal bodyfulness, which is like that term that I use to capture all of this. So what's the strategy here? We need to think in anti-inflammatory measures. So that is all the things. I think of anti-inflammatory measures very broadly when you were doing psychoeducation, very sensitive and culturally sensitive and attuned to the individual, psychoeducation about trauma. That's anti-inflammatory. Stress, the basic stress reduction. So a lot of the classic psychoanalytic treatment is about sitting for years and just reflecting. And it's like when you're dealing in the postpartum, you have to be very acute stress reduction here and now, because the intensity of stress can be so high. We need to really have immediate referrals. We need to work as a team. We need to be big on referring healthcare providers. What's going on here? Did you get your thyroid levels checked. You need to see a pelvic floor physiotherapist, nervous system, somatic work. My recommendation is if a person doesn't have a lot of training in that, can you add that on? Maybe you do individual therapy with some somatic components. Could you add on also other somatic things, right? So very kind of hands-on, acute anti-inflammatory measures to create that sense of a container because it's such a vulnerable time. And then the next part of the strategy is to support this assertion, which is an ongoing process. It's a slow process where the maternal embodied subjectivity is going to be slowly emerging. We need to be very co-regulatory attuned. We need to work with sensory awareness, sensory vocabulary, that's my somatic experiencing background. We focus a lot on that. And it's through that where that sense of a maternal body narrative and maternal body identity can build up. Sensory awareness is a big one here, I think, for the strategy, right? First, we do all that anti-inflammatory measures to stabilize, and then we can bring in the work where sensory awareness is big. And it has to be adapted, right, for the perinatal, right? So we do sensory awareness in different ways with different groups of people. So in my book, I have a whole chapter on that, on how to do it for the perinatal client. We have to be very gentle, very attuned to that specific intensity of the perinatal embodied state. And then eventually, when there is a progression here in these steps 1, 2, 3, then the third step of the strategy is to support the assertion of feminist or empowered mothering and the way that our client are finding their own resistance against these oppressive dynamics of institutional patriarchal motherhood. I put feminist empowered mothering here. That's actually, there's an important point about that. That is because empowered mothering is all forms of mothering that is about resisting the oppressive dynamics of patriarchal motherhood. But some people, feminist mothering is when you kind of identify as that. There are some people who would say, I am not a feminist. And they could still be mothering, parenting in ways where they're actively resisting the patriarchal motherhood. And it's just important to make that distinction. So all feminist mothering is empowered mothering, but not all empowered mothering is feminist mothering. So it's just important there to not kind of put our own values and political beliefs onto our clients, because they could identify their belief system could be many different ways that might not necessarily align with feminist philosophy. So what is it that the therapists need to know and do here? The main thing, I think, is that we need to build our capacity for embodied empathic attunement and work, and to work actively with the very specific transferential somatic dynamics of the perinatal transition. And we should build our confidence in our work by anchoring our interventions in this somatic attunement. Excuse me, we need to be highly sensitive to the particular shifts of the maternal transition. Our own countertransference reaction, we have a lot of reactions to the perinatal field. I call it the landscape of the perinatal nervous system, or the perinatal nervous system landscape. We will always have a lot of reactions to that. We need to be very sensitive to that. What are being brought up for ourselves, and then the way that perinatal trauma manifest in really unique ways, and then that co-regulatory nature of the therapeutic relationship and how that connects to the daily life of mothering. How are you setting up the physical reality of your work? Are you flexible? Are you able to work with someone bringing in a baby and sitting like this? If you're seeing someone in person, how is that impacting the therapeutic relationship? Can you integrate that? Can that be brought into it? And this is where we know we, of course, have to draw on the experiences of mother-infant or parent-infant psychotherapy, but we do have some long traditions of that, lots of insight to draw on there. So what we're moving towards, what we want to see is that we want to move from the maternal bodilessness towards maternal bodyfulness. We want to move away from that patriarchal institutionalized motherhood towards more empowered or feminist mothering. We want to see lessening of the dysregulation and too high levels of inflammation towards more of co-regulation. In a way, all of this is like saying the same, just saying it from the different paradigms or the different perspectives. And I want to make sure that we have time to have Q&A. So I'll just end by talking, just to clarify, maternal bodyfulness, because I mentioned that a lot. So I just want to wrap that up, talk about that. And then I will make sure we have time for Q&A. So maternal bodyfulness is a term that I developed from Christine Caldwell's term bodyfulness. I can highly recommend her book. I think it's a very beautiful and helpful term. So what is bodyfulness? Well, it starts with sensory awareness. That is a big part of it. Sensory awareness, awareness of sensation, being in connection with sensations on a very experiential level. But it is more than that. It is also to have an appreciation of the meaningfulness of our bodily expressions. There's a beautiful quote by Christine Caldwell. She says, "It is the wordless body that give our words meaning." There is no sense of like meaning making outside that foundation of the body. And this is, as you can hear, based on like, would say the philosophical background is phenomenology. I think it also aligns with Dave Abrams, the author of The Spell of the Sensuous. His way of thinking of a phenomenological, experiential sense of self, which is very much not just bodyfulness for the individual, but that sense of self on a bodily level is acutely connected to our relationship to the world and the non-human realm, all of the world, and certainly the world that is not dominated by human inventions. And it is through our expression of our body, the way we move around in the body, that's the building blocks of the body identity. So we move around the world. Even just today, you're going to be moving around your day. There's a narrative that builds up when you move around the world in your body. And from those body narratives, we form our bodily identity. And bodyfulness is that we can have a reflexivity about that. And we can be in a responsive connectedness to that. So maybe you've heard this term being psychological mindedness. It's kind of like that, but like related to the body. Mindedness, but with the body, bodyfulness, right? So I found this concept very, very powerful and helpful. And I was thinking, well, so what does this look like for the maternal transition? What does it look like what does our bodyfulness look like when we go through the transformation of having a baby? Well, I see that as this is the potential here for that resistance against the dictates of patriarchal motherhood. We can actively challenge this oppression of the maternal body, this idea that I have to live up to certain ways. My body as a maternal body could never live up to this abstract idea of the perfect maternal body, because that's no such thing. That is an institutionalized abstract illusion. There are only concrete maternal bodies in their context, right? So it's about supporting this deeper experiential embodied reflective knowledge about maternal subjectivity, that my new sense of self as a mother is very embodied. It builds from the body up. And it's about really engaging in the sensorial reorganization. That's why I want to work so much I love working with sensory awareness specific to the perinatal period, because when we really work with the specific perinatal sensations, we can support this, because that's the building blocks of that maternal sense of self in an embodied way. There is also a sense of struggle here, like the maternal transition is hard. The vulnerabilities we talked about, there's so many vulnerabilities of it, but it's about rediscovering your embodiment. Mothers will often talk about a sense of complete like fragmentation or disconnect from their bodies, and we talk about coming back to your a rediscovering and reclaiming of your embodiment, where also the political aspects come in, given your background and your identity and who you are and how you identify. So yeah, so that's it. I mean, I have a whole second part I could go on for a long time, but I want to make sure that we have time for Q&A. This is like a primer and opening. So I know there's a lot of information I put on you. As you can hear, I'm very passionate about all this stuff, but let me hear your questions, comments, thoughts, anything.
And as we move into Q&A, if we could just do that predominantly Western ritual of clapping for Dr. Vissing for your wonderful presentation.
Thank you. Thank you.
Woo woo!
Thank you.
And a welcome to our president, Maureen Harrington. Thank you for being here. I know you had a doctor's appointment, but I'm really glad you're here. So please offer any questions that you have to Dr. Vissing. And Dr. Vissing, I know you already manage Q&A on your own, so I'll just let you manage it on your own unless you want support.
Yeah, sure. Yeah. Any questions or comments, or could also be your experiences with this.
Hi, Dr. Vissing. I've got a quick question.
Yeah.
I'm curious how you think about moms who are in active states of trauma. So I worked with a new mom who had a really chaotic, volatile partner. And yeah, I'm just curious how you might think about both working on past trauma and active trauma with new moms at the same time.
Yeah. So when we're seeing really acute levels of high levels of stress with that related to trauma, and also with volatility, like safety issue, this is where we have to be so mindful of just stabilizing. There's often this weird thing where sometimes clinicians who are maybe not so specialized in this will say, oh, but it's there's trauma there that needs to be really targeted, and so we need to target that, go and do. And sometimes you can think, whoa, no, like this is a person who's like 3 weeks postpartum or a couple of months postpartum, right? That is not doable to go and do like weekly EMDR sessions where you're sitting and getting all stirred up, right? And then I also see the other thing. I see the other thing of like someone really dealing with high levels of trauma. So, and it's like, oh, but you have a baby. We can't talk about it. We can't touch it at all, right? Let's not talk. So it's very weird how I could see either of those. The thing is like to find a balance. And I think also we need to get away from this idea of like thinking of trauma in a very trauma treatment in a very protocol based way. So I have also a section on like with psychoeducation to say, trauma treatment isn't only that aspect of where you're doing kind of confrontation and more intense release. Trauma treatment is all of the healing components. And I think, but you have to make that known. You have to talk about that. So I'll have people come in and we say, well, we're going to talk about just stabilizing, safety first, safety, stabilizing, resourcing you, the whole kind of team approach. Get your social worker and everyone on board, all hands on deck. We're already doing trauma treatment. And maybe the person is like, oh yeah, I just need all this support, right? And before I can get to that part about how there was actually domestic violence and it was an abusive relationship, it's like, no, we're already doing trauma treatment is all of this, but it needs to be very carefully, gently done in a way. And the thing is, when we talk about trauma with the perinatal, we need to look at that in the whole lifespan, where that reproductive psych is something that goes back to early attachment, and before the birth and after, and in their later in their year, right? So a lifespan perspective is also really, really important. So that would be my initial, and be very clear in your psychoeducation about this. I have a section where I write out like very sensitive language for this, to to be very transparent, because that's also a principle of trauma-informed care. We need to be very transparent of how we see it. Like, this is what I see what's happening. This is what we need to do. It's all of it is trauma treatment, but it has different components.
Brilliant. Thank you so much.
I don't have a question, but I just want to thank you. I haven't gone to a presentation that has so much theory in it for quite a while. And the way that you integrated all these different pieces and your very out there politics, wonderful. I just really, really, I'm glad you're out there doing this work. I was in the Napa Infant Parent Program about 10 or 15 years ago, and you would have been such a great speaker because you went just for all the reasons I just said.
Well, thank you so much. Thank you. I very much appreciate that. I'm very happy to hear that. And yeah, like I said, yeah, I know there's a lot of like theory and research. I mean, I'm actually starting this year, after I wrote the book, to also do trainings that are very much experiential, because as much as I love the theory and research, I'm not only I mean, that it is in that programs where we do the real work with the clients out there. So I am incredibly grateful for my somatic experiencing training. It changed my life completely. I'm incredibly indebted to like that journey and the teachers I had there, the instructors. And that's the beauty of SE, is that it's something we can integrate with so many other approaches, right? So yeah, I'm very happy to hear that. And yeah, we have there's such a strong tradition and a ton of research and experience with the mother infant interventions, and I feel like a lot of it is like there and not being used so much in the new fields. It's like we have to dig up some of this. There used to be much more. There used to be much more family-oriented work. There used to be much more group-oriented work with, as we know, the whole era of managed care, sadly, has brought in just this focus on the individual, the focus on just medicalizing, sadly, we see a lot of that has that new families, new parents, new mothers, and infants are really suffering under those systems. Yeah.
I know we got to wrap up, and I want to just ask you a million questions. But one of them that I was sitting with today was affect synchrony. Feels like it's such a core part of that dyadic relationship, which requires kind of two subjectivities. And trauma makes affect synchrony, that ability to be in co-regulation, challenging in many ways. That, and then also some of those kind of disembodied states of freeze, and how they might be paired with fight or flight, and how that might make some of the new embodiment of this infant mother dyad more challenging. I want to ask you a million things. Sorry. So maybe that's just way too much for now.
No, I mean, yeah, affect synchrony is a huge part. Affect, there are some different terms, I think, are covering the same. Affect attunement. I am a big research geek. I have a chapter where I go through the whole research, Alan Shore and Peter Levine's research, and all of that is important. I did find that I needed to kind of speak the language of research to kind of prove like we already know, right, all of this. And I mean, Beatrice Beebe's research is like we're in the 50th year of that or something, 40, 50 years going. So we know this. There's that we really know it. Um, so yeah, so I really hope that um, I would really encourage you to also like take from this and like in your own directions if you work with like subspecialization or certain groups, right? Um, I just have this like more general and focusing on mothers, but I want you to I really invite anyone to kind of join me in this working with parents. It could be any number of like specific populations. We need so much focus on, I mean, certainly paternal bodyfulness, queer parents, parents dealing with specific issues, like in different groups, right? Like to bring in like, you know, indigenous groups, right, or Black mothers. Like I really invite anyone to take my work and to use it in any way, and evolve it and use it. I very much welcome that.
So, Dr. Vissing, I know we are right at time. I just want to say that Faith made a comment that 3 people have liked, and this feels very powerful. It sounds like she's really honoring your work. And if anybody would like to be in closer contact with us, feel free to drop your email in the chat, and we'll make sure we put you on our mailing list for NorCal SEPA. Could we give Dr. Vissing one more big hand? And we would love to grow Northern California Somatic Experiencing with you. If you haven't joined the professional association, please do. It's not a very expensive professional association, but a great opportunity for us to grow. And we'd like to thank Dr. Helen Vissing for her wonderful presentation. Dr. Vissing, if you'd like to connect, if people want to connect with you, how would they do that?
Yeah, my email contact at helenavissing.com. You can stay in touch there. Also, helenavissing.com, my website. You can find ways. I'm also on Instagram. But yes, feel free to stay in touch. I'd love to connect with any of you.
And I have a feeling you're going to continue to be this dynamic and creative through a long career. So I know we have lots to learn from you over the years. I'm very touched and inspired by your work, Dr. Vissing. Thank you for sharing it with us.
Thank you so
Our
much.
Yeah, and I want to give our president, Dr. I'm not sorry, our president, Mary Carrington, a hand. She's an SCP and a body worker, and I don't know if you want to say any closing words.
I wanted to say it's so wonderful to see all of you here. And did you mention, Mike, our in-person gathering coming up
Please do.
on April 19th? I don't have it in front of me. I believe it's 11 to 3. It's going to be at Gwen Gilson's home in Concord. And we have in place some COVID activity, so we can non-COVID activity, so we can all meet with community care. But yeah, we're gonna be able to see each other in person and engage and play and eat. It's a potluck. So if you're not on our mailing list, let us know in the chat and we'll get you on it. Thank you so much,
Thank you,
Dr.
Maureen.
Vissing. It was just wonderful. The snippet I heard, I'm like, wow, this is going to be valuable. I can't wait to listen to it again.
And we're going to go ahead and end. Look forward to being with you all and all of the creativity that we do together. Have a wonderful rest of your weekend.